My dear friends, today in our rural and semi-urban diabetes program, I have Dr. Manoj with me. Dr. Manoj is MBBS, MD, and he has got PG diploma in diabetes. The report which was released on the 7th of June, you know that Lancet paper, which
Yes,
said
sir.
the prevalence of diabetes in our country is 102 million.
Oh,
It was 72, now 102 million.
102
2
million.
million.
Oh.
And you know, that prevalence of diabetes is huge. And if it grows at this rate, it will become 675 million by 2040. So the diabetic population, if you take whole, the prevalence of eye disease is almost one third, and about one tenth of them have vision threatening retinopathy, which is called preventive blindness. You see, cataract preventive blindness, next to cataract is diabetic retinopathy. Now, I have shown here that how is the prevalence of diabetic retinopathy in the various types of diabetes. You take type 1 diabetes, you know
Yes.
it already.
Yeah.
By the time 5 years, about 15%.
Percent.
If they're by 10 years, they're about 50%. And by 30 years, type 1 diabetes, almost everybody. If you take type 2 diabetes, which is bread and butter, of course, I know you also work in type 1 diabetes. By 10 years, it is 50 to 70%. At the time of diagnosis, Dr. Manoj, it's about 50 to 30%.
Oh.
So we insist on inspecting that now on the day one.
Sure.
And by the 30 years, it is 90%.
90%.
So it's very hugely prevalent. I have shown here the risk factors for development of diabetic retinopathy, but most important, duration of diabetes.
Yes, definitely.
But next important is the poor diabetes or glycemic control. So we want to address it today.
Yeah,
There are
sure.
other issues like genetics, but
Yeah.
as you know, we cannot choose our parents.
Definitely.
We cannot choose you can also not choose your in-laws.
Sure.
But we can only correct the
Mhm.
correctable factors, modifiable factors.
Okay.
The modifiable factors are blood pressure,
Blood pressure.
very important for retinopathy, diabetic nephropathy, because nephropathy is the fertile soil
Related with-
on which retinopathy, called renoretinal disease,
Fine.
renoretinal association, and also pregnancy.
Oh,
You know
sure.
better because your wife is gynecologist.
Definitely.
You know that every 2 weeks we have to look after the eyes in
Glycemic
that
control.
pregnancy. The other factors are cholesterol and etc. etc. I will not take time. Now, what is the strategy that we can early detect retinopathy and take care of it? Principal risk factor for diabetic retinopathy is uncontrolled diabetes. Again, and I am harping on this point because we have to control. So the only strategy at the early diabetes is to control diabetes. Now, it has been shown that when the disease advances, you can do photocoagulation, you can do vitreal surgery, you can do maculopathy, photocoagulation, but there are a lot of adverse effects.
Definitely.
Nothing like prevention. We
Prevention
asked
is better.
somebody, Eva Conner from the Hammersmith Hospital. I was in King's.
Okay.
Hammersmith Hospital, she said, nothing like preventing diabetes, preventing retinopathy by good control. And you know, the very important, we have to screen for it.
Okay.
Because diabetes silent killer, they're silent killer. This is what is very important, Manoj, to my mind, that there's a legacy effect. If you control early and control very much, there is low risk of complication. If you do not control, they will remain at this stage. If you do not control early, the retinopathy goes high. So this is called the legacy effect.
Okay.
So the long-standing hyperglycemia generates glycemic memory. So that's called legacy. You know about it.
Yeah, sure.
So we want to do the early aggressive control, and oxidative stress also an important issue.
Definitely.
But I'll come to the final slide, which says that what is the benefits of insulin therapy? It has been shown when retinopathy sets in, it is beyond the stage of good control.
Sure.
There from the very beginning itself, we have to take care of diabetes by good control, and for the good control, along with oral, we need insulin.
Okay.
As you know, in our country, the insulin intake is only about
Definitely.
21%.
Sure.
Now we are popularizing more insulin, only appropriate case. I know
Really,
it, not to Tom, Dick and Harry.
In rural areas also the same issue.
Same.
They are very panic of insulin.
That's right.
So
They
we have
think
to
it is
just
once injection,
educating
lifelong
them. Yeah,
injection, which is not
definitely.
true.
It has so adverse
So many
effect, they are
myths.
saying, but we are keep on promoting the
Insulin,
benefits of insulin.
Insulin. I'm very passionate to tell you, amongst all these benefits, the most important benefit is what I read in BMJ. Now, most important is that the long-term beneficial effect is delaying the complications,
Yeah, sure.
prolonging the life. You know, Mohan, my friend, he
Mhm.
does 100 years diabetes survival on meeting and
Oh.
gives them prizes.
Right.
All the 100 years survival,
Mhm.
mostly because of insulin.
Very nice.
And you know, we have new drugs,
Sure.
oral drugs,
Sure.
but nothing like insulin. And most important, Manoj,
Mhm.
is that it gives a great sense of well-being.
Mm.
You feel much better while on insulin.
Okay.
Therefore, the intensive. So there are two things I will tell you. We start insulin late and intensify still late. This is the last slide, which says that in all the guidelines I have taken from ADA, ASD, our own RSD guideline,
Okay.
it is important to remember
Sure.
when the insulin is called for, we should not shy away.
Okay.
Therefore, we can say, and so what is the insulin you give? We believe in give basal insulin.
Mhm.
Now today glargine has become very cheap.
Cheap. Yeah.
It has gone off patent,
Yep.
and everything is 600 rupees. So we can give the best insulin.
Yeah.
We start with 10 units daily,
Okay.
and 2 to 4 units we can increase twice a week, and this control the fasting.
Right.
If necessary, we can add some basal insulin. So very easy way to do it, and we can take care of retinopathy.
Yeah.
So Manoj, I'm very happy that
Yeah.
I
Thank
talked
you.
to
Sir. Thank you.
and I'll be going to everybody talk.
Sure. Sure. Sir.
Delighted.
Very nice.
All the best for you.
Thank you.
And delighted to meet you.
Thank you
And
so much.
it's a great.
You are always welcome.
Thank
Thank
you.
you. Thank you.
Thank you.
Thank
Thank you very much.